No, not yet, not yet. Only the few UK variants were there actually.
Yeah. Our like, I don't know, our volumes are plateauing, but I think there's a real fear that because people's behavior is changing after the vaccine, that our volumes are about to go up again.
Oh God.
We're dealing with a large outbreak right now on the Hopkins campus.
Oh, so that. So, are you vaccinated, Bhakti? You took a vaccine?
Yeah, I got vaccinated in January, but I got COVID in March last year. So I am antibodies galore. I have so many
Okay.
antibodies. And I just had a baby, so I have a 3-month-old right now.
Oh,
Busy mom
congratulations.
life.
Congratulations.
Thank you. I want to come back to India though. You have to find an excuse for me to come visit you.
Yeah. Hope to see you soon.
So I might kick us off a little bit just because
So,
in true Indian style, I want to do an introduction before introductions. And so, as people have assumed from Sanjeev and I chatting, Dr. Boy and I have known each other since around 2008, 2009. And at that point, he was already the head of his department. He was at Ames Delhi. He was in a trauma unit director. And I was this young resident, bright eyed, wanting to change the world, had very big ideas. And, what always surprised me in retrospect is the humility, right? So all of these people from around the world came for this Indus EM summit. There was all of these lecturers thinking that they know what is best. And Sanjeev and Praveen were like, come on stage, tell us what you want to tell us. We'll learn. We're always willing to learn. And then he took me to his ICU. And in the ICU, I see capabilities that I've never seen in the US. I saw portable CT scanners, I saw ultrasound machines at every corner, I saw one-to-one nursing ratios and amazing documentation. And I think that speaks a lot about who our speaker is today. He's a lifelong learner. He's humble beyond words, especially since he runs one of the biggest and most capable trauma units in India. He is kind, he's intelligent. He recently just had a New England Journal of Medicine publication. So it is with great honor that I get to do this informal introduction of my friend and colleague, Dr. Boy. And I'm going to hand over to Dr. Nico Risco to do a more formal introduction. But I'm excited that our world clashed again today and that you get to be here, me in a very different role and you also in a very different role. But the syntax is always the same. It's about lifelong learning and education and exchange.
Thank you very much, Bhakti. Today, we are very lucky to have Dr. Sanjeev Bhoi, who is Professor of Emergency Medicine at the All India Institute of Medical Sciences, also head of the WHO Collaborating Center for Emergency and Trauma in the Southeast Asia region. He's been elected as director of the board of directors of WADEM, the World Association of Disaster and Emergency Medicine, and has trained tens of thousands in basic emergency care. Somehow still makes time to share his expertise with us on ultrasound as a clinical tool in the setting of the COVID pandemic, which is the topic of our discussion today. So Professor Bhoi, we are honored to have you here today. We're very excited about the opportunity to learn from you, and I will pass the mic over to you.
Thank you. Just a minute.
No problem. Feel free to take over the screen. And as people have questions as the presentation goes along, feel free to put them in the chat or raise your hand or feel free to speak up.
Can you see my screen and am I audible?
Yes, we can hear you and see your slides.
Okay. So thank you for that kind introduction, Dr. Bhakti and also Dr. Nico. It has been a pleasure sharing our experience and also the concept of point of care ultrasound in COVID-19 pandemic. So I'll go a little bit slightly modified. My topic is, yes, we're going to speak focus as a tool in COVID-19 pandemic. I am going to load you today with the current status of research, current evidence which is there in COVID-19 pandemic. So this all starts with the March 2020, when we are preparing to brace up for COVID-19 pandemic management. And since we have the expertise of point of care ultrasound, and we are facing a respiratory epidemic, so it actually came into the back of the mind, that we are actually a resource limited setting, especially countries like us, and we have lack of resources, because that is the time when actually we are facing that what will be the imaging modality, and such as chest X-ray or CT scan, and how this point of care ultrasound can be utilized as a tool for initial triage, research, and critical care. So we'll go and see one by one on that. So yes, so it is a, we are within the pandemic, and it is a ever growing caseloads across the globe, and still, and it produces a huge challenge actually to the both the frontline emergency room, the critical care units, and the hallways, and also in the ward, because you require one of the important imaging tool is chest X-ray or CT scan, and that it actually overwhelms the radiological search capacity. And we know that because of COVID-19, it is a highly infectious case, and you require the radiology suites to be actually sanitized for the next patient. So these are some of the challenges which we faced during the, during the frontline management, and we're looking for an answer. So just a minute. So the issues and challenges were, how do you actually examine, because you are all in coverall suits, it becomes really difficult for examining a patient hearing respiratory sound. It may not be always feasible. So with a famous dictum, if you read the very famous line is the role of, use of point of care ultrasound as a visual stethoscope. But on the conventional stethoscope, it is really difficult, and it actually brought out the concept that where you can use less stethoscope and more ultrasound, because it is a visual stethoscope of 21st century. So this was one of the apt time to actually reassign the role of point of care ultrasound as a visual exam. So you have quick scans, and with a rapid turnover of patients, you can use it very frequently. With use of low-level disinfectant, it can have the game-changing position for initial triage and resuscitation. So other diagnostic issues and challenges were, yes, you require RT-PCR. RT-PCR actually takes around 6 to 8 hours to get a result, and you have patient load in the front line. It is difficult to use it as a triage tool. Chest X-ray and CT scan, it has got, though chest X-ray has a sensitivity of only 20%, and but so it has been also utilized. Again, it takes time to get a chest X-ray done on the front line. CT scan, it has got a high sensitivity but low specificity, just like ultrasonography. So we had, but getting a CT suit, again, it takes, especially resource limited setting where you have also non-COVID patient eyeing for the same resources, so it will become difficult for getting sanitized. I have a dedicated CT scanner for COVID-19. So there are huge, issues also from the radiology colleagues, that how to get CT scan done. So I looked at we did an extensive literature search and used the as a Prisma flow diagram. We searched a record identified through database was 501, and we're able to actually, the studies included is getting a qualitative synthesis of 115 patients, 115 studies looked at as per December 31st, 2020. And the literature reviews were mainly, they were, the literature based on editorial letters, editorial commentaries, case series and case reports, cohort studies, control studies were none actually, and evidence-based reviews and systemic reviews were 22. So a flooding of the literature, at that point of time, and there are no meta-analysis when I search up to till December. So that means there are a lot of, while the focus was globally on chest X-ray and CT scan, also the group in ultrasonography, actually they are doing their shots of writing editorial advocacy articles and a few case reports and case studies. So we also thought in April, actually March and April, planned a study, to use point of care ultrasound as a tool in the initial assessment in the triage area, and looked at some of the patterns, lung ultrasound findings, what you can get in COVID-19. Before that, there were two papers of case series of 20 each. So we know that the utilization of POCUS in COVID care is, you can do a COVID screening, stratification, and diagnosis by using lung ultrasound, patient monitoring. You can also do, the other non-extrapulmonary ultrasound can be done in focus echo, venous ultrasonography, portable handheld, and you can use also remote teleconsultation through using POCUS because of the newer handheld device with a streaming platform. So because we know it is thrombotic events, so both lung and thrombotic events can be picked up by using POCUS. So this was one of our published study. We published, you can see in May 2020, early part of the COVID, and we proposed a algorithm which was published in Postgraduate Medical Journal, BMJ publication, where we looked at using ultrasonography in the initial triage area and the emergency department and what you can do in critical care setting. This algorithm actually divides into a mild and clinical group, where the patient, the POCUS, which already has got 100. If you see in the future slide, I'll speak about that, with a sensitivity of 90%, 95%, and a negative predictive value of 95%. So you can use it on the front line, and decide whether the patient goes inside the facility, or you can use a home isolation or home quarantine methodology by putting it in the front line. So let's see one of the key features which you can use by using a lung sonography. If you read the famous paper by Daniel Lykensin, where he was the game changer in chest into way back in 2005, where ultrasound is not a villain to lung ultrasound, but not a villain to air, but the artifacts, related to produced by ultrasonography is actually uh, is a is a friend, picking up lung signs, for discovering conditions, such as pneumothorax, pleural effusion, pneumonias, ARDS, pulmonary edema, and variety of conditions you can pick up with a good diagnostic accuracy when compared to chest X-ray and CT scan. Other famous paper in chest, which gave a sudden, relook of using ultrasound in lung, aerated lung, which was considered one of the villain of that. So this actually, the strength of this lung ultrasound became the nidus for doing many studies, in this respiratory epidemic. If you see Penang et al., and Huang et al., they published 2020 papers, and there is one, Pagali also published a small series of 12. So when it was going on, this was time actually we did our study to give impetus to the research of point of care ultrasound or lung sonography in COVID-19, because majority of the people were actually focusing on doing a CT scan. And if you see the hinterlands of India or periphery or countries like us, even in the smaller cities, people are, even with asymptomatic COVID positive, people are doing actually CT scans, which is not required, neither for diagnosis nor for monitoring of the patient, and it is resource intensive. It has got radiation. Your patient has to shell a lot of money, and for nothing. So actually, that is the time we worked on this paper, which is now published. One can look at is the lung sonography finding in COVID-19, and there is now so much of research in this. So you can see few lung sonographic finding you can appreciate here is one can see is the variety of patterns. You can see the shredding. First is the pleural shedding. You can see in the arrow in the first box, you can have pleural shedding. The number two picture, suggestive of pleural thickening is more than 2 millimeter. If it is there, it is called pleural thickening. It was one of the finding. And third is stretch sign. The third box shows stretch sign. You can see that. And there is the lower half or bottom half of the screen. You can see which is flooded with, you know, uh, flooded with, you can say, B profile. You can see the whole white thing which is coming down from the top of pleural line, just like a waterfall, looks like a waterfall, which is also called as a waterfall sign, which has got nothing but confluent B lines present in the lung. So, which suggests there is subpleural consolidation, and these findings are bilateral in COVID-19. So, COVID-19 is a bilateral B profile, you have stretch sign, you have pleural thickening. So, these are the findings in COVID-19 in the lung. And this has been already well studied and well correlated. There is one paper which correlates well with the CT finding. The confluent B lines is actually, or the waterfall sign, which correlates very well with ground glass appearance of the CT scan. So, and you can pick up pleural thickening. Also, you can pick up pleural thickening in CT scan. So, these are, and subpleural or peripherally based consolidation can easily be picked up by looking at stretch sign, and it is picked up by peripheral based opacities in the CT scan. The pleural effusion is rare in case of, it is not very common finding in lung ultrasound finding in COVID-19. So it is as good as CT scan studies has shown. So the incidence of specific finding which we picked up with our study, you can see you can very well see here the screen, that we looked at we did this study in almost 106 patients of RT-PCR positive, and you can see bilateral, lung, the right lung and the left lung. You can appreciate there that the bilateral zone 3 and zone 4, their bilateral involvement are present in terms of pleural shedding, B profile are present in both. So these are the two common things which we found: bilateral B profile and pleural shedding, mainly located in lung zone 3, means peripheral part of the lung, which is well described as a pathophysiology in COVID-19. And the other sporadic findings, what you get is pleural thickening or B line less than 3 per hyperfilled, confluent B lines were less. So what I'm trying to say is, more the severity of COVID-19, the more the positive findings they have. There is a linear correlationship between the amount of finding in the lung and the severity of COVID-19. So there is one paper which talked about it is the clinical POCUS or clinical gestalt. It is better. By if you read a very nice paper by Emil et al., if you read Annals of Emergency Medicine, where actually what he did is he did use clinical gestalt with POCUS, versus clinical, and he used with RT-PCR as a reference method, and RT-PCR he repeated twice. So once at the and the baseline, and one after 72 hours. So what he did is, he with this he proved that there is a sensitivity of almost 95% with clinical and POCUS gestalt, and when compared with initial RT-PCR, which was only 80%, and has a 95% negative predictive value. So you can see that it has got a good sensitivity and good negative predictive value when compared to the initial RT-PCR result. Initially patient come, you do RT-PCR. So that means that almost 21 patients, resulted positive in the second PCR. So initially the patient, they were missed, 21 patients were missed in initial RT-PCR, and they were reclassified, as COVID-19 because on the second step PCR, because with a high degree of pretest probability of COVID-19 by clinical and POCUS, the clinicians, they followed up the patient and repeated a RT-PCR after 72 hours. So that means it is very important that POCUS with integration with initial assessment is key, and it can be very helpful. So this is the paper I was talking about, is where Pang generally actually correlated the findings of lung ultrasonography with CT scan. So it matches 1-to-1 in more, but one of the flaws or limitations of lung ultrasonography it cannot pick up deep-seated lesions. Deep-seated pneumonia cannot be picked up by lung ultrasonography when compared to CT scan. The rest of the things like, multilobar distribution, confluent B line, so it is all correlated well with the lung CT scan. So that means it can initial part, it is a beautiful, that means a beautiful tool for initial assessment and management, initial in the front line, in the triage and in the emergency room, till the patient actually shift to the critical care unit, you know, and there you can use CT scans and for monitoring and evaluation. Yes, for litho limited, it can also be used for monitoring. But here you see, in other settings, there are studies very well documented in both pediatric settings and also in pregnancy. Even in neonates, COVID-19 positive, they have utilized. In fact, in the pediatric and neonate setting, lung ultrasound is very helpful. The other important people have looked on now because doing a B-line scoring, so the quantification of the involvement of lung and with and monitoring this patient. So there is a B-line scoring. There is, you can go through that. The articles people are doing scoring both right lung and left lung, and look for when giving therapy whether the patient is improving or deteriorating. So if you do not have CT scanner, you can still use it, even monitoring in the critical care unit. Or the patient when he is recovering, whether he is disappearance of B lines or not. Or in follow-ups, or nowadays there are studies coming up following in follow-up, people can use this thing in the community settings, smaller centers, whether the patient is having persistence of B line, whether they are developing pleural fibrosis, whether the patient who have been recovered and coming back with respiratory distress nowadays, you can again do lung ultrasound, seeing whether the patient has developing, say, lung fibrosis. So it has got even that in the present, already we are 1 year. Now you will have lost a lot of follow-up patients. You can do lung ultrasound in community level. No need to do repeat chest X-ray, or even which is less sensitive. Or you should not use CT scan in community center or follow-up clinics. Even people have used one paper which people have looked at, self-monitoring by people who can afford a small pocket-sized lung ultrasound. So the differentiation from both ARDS and cardiogenic pulmonary edema, you can easily do it by using lung ultrasonography, because we know that COVID-19 can present with you with both respiratory and extra pulmonary complications such as myocarditis. With cardiogenic pulmonary edema can also be there. So, and or the patient is developing, say, ARDS. So there are specific signs. You can easily differentiate between all these factors by using point of care ultrasound. Monitoring of mechanically ventilated, so you can pick up, complications such as atelectasis or a bacterial VAP, ventilator associated pneumonia. You can guide the therapy by seeing more recruitability, or you can even do PEEP titration in the critical care settings. I just rush through and go a little bit on because why it is so important is extra pulmonary complication, as they say, stroke, STEMI, even acute pulmonary embolism, venous thromboembolism is also so important in this pandemic. So we know that the association of cardiovascular disease and pre-existing cardiac 10 more comorbid with COVID-19 has a high mortality. So it is very important that to do a POCUS, if the patient when they come, does he have a pre-existing cardiac disease, you can do a look at the ejection fraction before this thing, or the patient has got a myocarditis associated. So more the evaluation of cardiovascular disease, pre-existing or a normal heart, and with COVID, so it makes a difference. Those are more cardiovascular disease, they can pick up, so the association of mortality is very high. So various findings have been suggested, has been come out in the literature during this pandemic. It can involve everything possible. It can cause acute pulmonary embolism. It can cause myocarditis. It can cause Takotsubo cardiomyopathy. That means stress cardiomyopathy. Rule out everything and still there is ballooning of the LV. Again, it presents that. So right from both systolic dysfunction to diastolic dysfunction, everything is possible, has been documented. for involvement of cardiac complication, which can picked up by a cardiac ultrasonography. And it can be done easily if you are a trained person. So it is important that most of this cardiac injury actually, either they have been suggested that there is a thrombotic or obstructive phenomena or a non-obstructive phenomena. In obstructive phenomena, yes, you see that if there is regional wall motion abnormality, it is imperative because there may be obstructive coronary usually, and who has got a say a normal cardiac contractility, and still the patient has ST segment elevation, here, and non-obstructive coronary will not have a regional wall motion abnormality, but they will have a myocardial injury with non-obstructive coronary artery. It has been also documented. Venous ultrasonography, it is quick. You can use. You should be doing it because even in asymptomatics, you should be doing weekly. Those who are in IC setting should be doing a compression ultrasonography weekly. Even if there are patients who are asymptomatic, it has been found there are thrombus, in the lower limbs. You can use associated to regularly to look for the findings of thrombus, and you can use other algorithms for looking at, because these patients are also known to have multi-organ dysfunction because of lung, cardiac, and use of fluid. Judicious use of fluid is very important. So you can use protocols like rush protocol. If you find a undifferentiated shock, you must do a rush protocol, that is rapid ultrasound in shock. Look at the cardiac function, associated B profile in the lung, and look at the inferior vena cava, or look at use the false protocol, that is called as the fluid abuse limited by lung sonography. It is very important not to overload the patient, in a shock patient with COVID with lot of fluids, because the patient may be having underlying myocarditis or having a poor cardiac function and you put a lot fluids. So it is very important to combine cardiac, lung, and IVC and look for, limit the fluid as required. So it has been recommended by many societies that regular ultrasound screening for COVID, this I talked about just now, that you must scan regularly. And there are few algorithms, many, if you see the literature, there are many algorithms has been suggested, in during this pandemic, such as a mnemonic very nicely put it as COVID. C for cardiac evaluation, O for outputs, V during ventilations, E you can use it during intubations, such as. So other algorithms like delete, like you can do a DVT or lung exam echo in 10-minute exam. And there another very interesting is try-POCUS approach. So if you see organ talking, lung, heart, and IVC, which I was talking about, and we put out one of our own algorithm, two more algorithms which we published, was POCUS, a dynamic tool during rapid sequence intubation. So this is very important because you are unable to confirm, sometimes, by using a ETCO2, while even ETCO2, you have to also push few AMBU you have to do. And for initial 6 ventilations, you need to do after 6 ventilation, if they persist in the ETCO2, then you say it is in the trachea. It has got own share of aerosol generation. So that's why if you are trained ultrasonography, you can use it, by putting the probe directly on the esophagus on the left side is step 1. When you intubate, if it say the tube goes to the esophagus, it will cause a double track sign, and then immediately you can remove the tube and re-intubate. So that means the esophageal intubation. If you put a tube and if you see the esophagus very nicely, that means you are in the trachea. That is step 1 you have to do. In step 2, what you do is, put the probe on the left side of the lung and look for lung sliding. So if the lung sliding is present in step 2, it tells you two things. One, you have intubated in the trachea, and second, it tells you the tube is in the center. So that is how you can use POCUS during RSI in COVID-19. And finally, we propose how you can integrate point of care ultrasound during CPR in COVID-19 patients. We know that the proposed sono algorithm which we did is CPR you should start as per standard protocol. After you've done the PPE, after 2 minutes start CPR. Don't interrupt. Give 2 minutes. If the absence, cardiac activity, so after 2 minutes you put a do a ET tube, means and do a endotracheal intubation and look for any double track sign or a bilateral lung signing for tube confirmation. You can use, then continue CPR and keep on assessing rhythms every 2 minutes, for 10 seconds. In the next, after you have done chest activity, so cardiac activity, ET tube intubation in the third, you can use, lung scan, to rule out absent lung sliding. Sometimes you develop tension pneumothorax, and after continue CPR again after 2 minutes, do a while doing rhythm check. Actually, you can do a cardiac scan here, you know. So here you can pick up, regional wall motion abnormality. If there is a myocardial infarction, and you can treat accordingly. Either a feature of RA-RV dilatation if you have. So if you can look for any pulmonary embolism, okay. So that is so critical. And the treatment here is you can give during extremis the dose of altiplase or tenecteplase. And you can also pick up fine VF, which is very important, very important when you see a flat line on the screen. When you're doing cardiac scan, sometimes the monitor will show you flat line, but if you see the echo, it will show fine VF. Here, the treatment algorithm completely changes because one is a shockable rhythm and one is a non-shockable rhythm. So with a flat line, don't have to do anything much, and you continue the non-shockable rhythm algorithm, but here need to shock. Or we have seen patients coming to in COVID-19 has coming with tamponade. We have seen with pericardial effusion with tamponade coming to with COVID-19. You can address that by doing a POCUS. So this is how actually the algorithm is. If you want to read more about it, please go through the paper published by our group in Postgraduate Medical Journal very recently. And the team dynamics is there on the right side. The ultrasound person is a different guy with ultrasound device. Best is to, you should have a ultrasound which is cover all. You can put the polythene cover all over the this thing on the you can see the ultrasound machine. Very important. You should actually cover the probe with a endoscope cover all this thing, and then you can scan. So it is very important. Use a low level disinfectant, low level disinfectant like sterilium, or you can use it sterilium on the low level disinfectant and use it for the patient. So you can change from the when the next patient, again you can use another coverall, probe sheath cover just like endoscope, and again use a low level disinfectant and you can use it. So this is how you actually protect your ultrasound machine and sterilize it, so it is better. The best is if you have a handheld device, without any, so it is very important with a touch screen, which is very helpful during the whole ultrasound this thing, and it is easier to disinfect also, and you can use it better. But many centers which is not available. So with the existing old machines, you can put a whole polythene cover and you can use it. So that is how you do. And this is the dynamics if you want to go more and read about that. So these are some of the portable handheld, the last segment is portable handheld machines. As I said, that it is reasonable compromise between portability and capability. We don't require much capability. You just have to do a lung ultrasound, cardiac. You don't require any calculations, so you have to look for, do a focus goal directed echo. You have to do a lungs ultrasound. You do a venous tree scan. You don't require much capable ultrasonography. And as I said, it is easier to protect from viral contamination. You can also do, because of the newer machine, there is POCUS and teleconsultation. You can do live streaming. If somebody is not a very trained person, there is a nurse. You can do live streaming and actually guide where to put the probe. You can see in this slide, it can reduce. You don't want to go in. You can ask the healthcare worker, a nurse, to where to keep the probe, and the live streaming can be there in a remote location. So it reduces chances to healthcare workers, remote guidance, or you can do over untrained healthcare practitioner, and remote guided self-scanning also one can do. So these are some of the advantage of newer technology, and you can use. You can very famously call it butterfly. There is a new machine called a butterfly. You can just put the probe on your own mobile, you can download the app, and you can start scanning. Very helpful, but is not available in our country, actually in India. There in US, I saw last year when I went to teach an ultrasound course in Miami. These are some of the ongoing research. If you want to look for more research or more evidence in COVID, use of point of care ultrasonography, many studies are going on. Yes, there's a lot of buzz, and this buzz has led to people, more and more people are using point of care ultrasonography both in adult and pediatric setting. However, pediatric setting people are using less. I encourage most of to use this even in pediatric settings, though the evidence is not great, but because people are using less, yes, more and more use will be helpful for the patient on the front line. I am sure with more studies the noise will definitely set down. There is a good paper one can read in critical care where the consensus group actually has enumerated the evidence of right from head to toe examination by using point of care ultrasonography. But yes, I would agree that you should use it judiciously, and where to use, how to actually do use, how to become safe with the ultrasound machine, how to sterilize them, how to sanitize them, what are the protocols you should use. There should be defined protocols. There is, if you see, the defined machines has got different protocols for disinfection of different way. You can go to the, say, for example, Sonosite has got their website, they have written in G, they have their own, come out with their own guidelines. So please look at your ultrasound machine for disinfection, what is the criteria, and please do it diligently. So, and remember that it is very important that it should be done with algorithmic approaches, and reviews one should be doing by doing in different shifts. So you should keep on communicating, and documentation is key. So this is all about point of care ultrasonography in during COVID-19. And in our center at All India Institute of Medical Sciences, Delhi, we have used a lot of point of care ultrasound in the front line. We have trained all our residents. They are using it during in the triage and initial assessment, and also in the critical care setting. We have not done a single CT scan in the emergency department pertaining to COVID-19 lung. We have not used that. We have used more of POCUS. So in those patients who are actually admitted in the ICU, the ICU people, they have used CT scans for their monitoring and evaluation and treatment. But this actually decreases, it decreased our radiological search capacity, that, our patients did not go for any CT scan, and we use more of this thing and less of chest X-ray as well. So this is what the experience was from our center. And last 1 month, actually, we had the global conference of POCUS, point of care ultrasound in COVID-19. In the last whole 1 month, we had 4 weeks of sessions, and there was good presentations, and this thing we just concluded last week. So it was also great learning, and a great learning that what is happening globally, right from US to Australia to UK to Middle East and India. So what is happening in different parts of the world, including Africa. So with shared experiences. So this is all about focus in this COVID-19 pandemic, and there is a lot of pandemic of also, the information has also become like a pandemic. The focus research is also the pandemic in the focus research also. So thank you very much for listening to me. Happy to take any questions if there are.
Thank you so much for the excellent presentation, Professor Boy. I think we all learned quite a bit, and we're now going to open up for questions and discussion. Please feel free to enter questions into the chat, or raise your hand, or feel free to turn off your mic and speak up. I'll kick off the question session with a quick question of my own, Dr. Boy. For us, as a group that provides technical assistance for COVID across many countries, seems like point of care ultrasound is an area we should be focusing more on. I wonder if we are, supporting the acquisition of radiology equipment, and we're putting resources into training materials for hospitals, maybe smaller hospitals, something at or below the district level. Do you think from a dollars and cents perspective, it makes more sense to focus on increasing X-ray capacity or ultrasound capacity?
Very good question. So here you see that one should, based on this available literature and use, you can see that it really addresses the radiological search capacity. Even in the future, if we see once we use this in the point of care ultrasound in the say district level or provincial level hospitals, it will be a game changer because not only it will help in the current pandemic, in the future it will be a resource for using it in the primary care point of, because anyway the diagnostics such as x-ray, so that's ct scan are not available in smaller primary care. So it has resource intensive, you require a particular radiographer to be there. Even you are say putting a x-ray machine, by up to 2 o'clock he'll be there, from morning to 2 o'clock he'll be there, then after that he'll not be available. But if you put a point of care ultrasonography machine, and if you train the say doctors and the nurses, as a task shifting model, so the patient they can use it not only for initial resuscitation and early diagnosis, and it will maybe empowering to take critical treatment decisions, beyond COVID as well. So it is here the current pandemic definitely going to help because it is a good tool. We have shown in our study as well, which is published. One can look at that, and here it can definitely reduces the need for chest X-ray, which is less sensitive, especially in this COVID-19, less sensitive, and as a diagnostic test itself, it scores much beyond than chest X-ray. However, I with this I would definitely like that the smart move will be actually to empower the district hospital with point of care ultrasonography.
Thank you. And we have a hand raised, Tej
Yeah.
Prakash. Go ahead
Yeah.
and ask your question.
Yes. Thanks. Thanks, Professor Bhoi sir. So just I wanted to add, as Nico has just raised that way forward, or utilizing point of care ultrasound in enhancing the response to COVID-19, or you can say second wave is coming up. Many countries are going on like that. So we have few experiences working with very rural areas where ultrasound is there due to maternal child care. So this is available. Second is building a system for doing POCUS is much easier if you compare with X-rays, because it is costly, space, then manpower, and above all, as Professor Bhoi mentioned, that is not that great sensitive. Additionally, it is limited to only those which are amenable to X-rays, like chest is one, maybe some bones or something like that. But if we have a point of care ultrasound, it can have a 360-degree approach going to IVC or volume assessment, cardiac assessment, even many other issues which can be handled by ultrasound, not only the lungs. So lung is obviously one focus. Second is, this is a bulky one compared with the ultrasound, this X-rays. So cleaning it, sterilization, cross-infection, this again is a big concern. Third is regarding training, we can, if we compare with the X-ray, reading X-ray, which is having a limitation, radiation. So teaching or training is not that tough. The learning curve is not that long. Additionally, we can use telemedicine in a big way, which can reduce the burden of you can say image processing, or you can say decision making. So I also agree that we have to put a lot of thrust on making this point of care diagnostic as a part of point of care diagnostic, point of care ultrasound, and that system will help in coming time also. So that is my take on this. Thank you.
Thank you. We have a question in the chat. Um, Dr. Boy, what is your view? And I don't know what this act is, the PNDT Act, and its effect on POCUS adoption in the ICU, also at nursing homes and the small hospital level. And maybe we could just mention what that act
Yeah.
is.
Yeah, so this is as I and responded by even Bhakti that the PNDT Act. See, PNDT Act is nothing but prenatal, determination, sex determination. This is so that there is a issue here in this part in our country, especially in India, that because of the female feticide, so the diagnostic centers and the doctor has been charged that they do illegal determination of sex, while they are doing ultrasonography, especially in female reproductive age group female patients. So that's why the act actually says that it is there are certain provisions of the act that you should be trained actually trained in ultrasonography. Yes, it requires a defined core competency, and any medical officer has to take training for at least 6 months, to get and get yourself registered in the PNDT register. Then you are legalized to practice ultrasonography and this thing. And yes, so if you follow the rule of the law, nothing is going to happen. That is number one. Number two is they say that you need to maintain a register. Yes, people do maintain register. Yes, so that is another thing. Third is, suppose you are already a trained person. Say trained means if you have done a residency, say in emergency medicine, or you have certain clinical discipline, even by Medical Council of India, has been mandated that you should be doing, you should be trained in point of care ultrasound. The actually mandate came in 2 years back by Professor Mishra. That that all clinical specialties should undergo a point of care ultrasound training, and in the mandate of say critical care, especially in emergency medicine, they have to do it a core competency even for 3 years. 3 years you have to do. So that means they're already trained, and when they are inside, they have to get themselves registered. Even I have also registered myself in the PNDT register. So that means every medical practitioner, if they follow the rule of land, then nothing going to happen. So that means there are black sheep everywhere. So if you are resuscitating a patient, and you with the intent of resuscitating or saving life, if you use point of care ultrasound, it is not going to be a big issue. Third is if you use it during disasters. So even the Disaster Act also protects you for using it. Yes, this has to. There are certain sections of our country where it is they have totally banned it. So suppose and they have been quite vindicative of the doctors. So there is some issues are there, but over a period of time, yes, it will move on, because we, especially in academic centers, it is not an issue. Smaller this thing, I would say smaller nursing home and hospital, you need to register yourself, and I should not be and provide details and have regular inspection. There should not be any problem, because that is the way it is right now. So yes, the another question by is the adoption of ultrasound availability challenging adoption of evidence-based ages. Yes, this is a good question by Dr. Bhakti. Is one other thing is ultrasonography machines are available in every district hospital because of the maternal and child health program across the country. It is available, to actually pick up high risk pregnancy. It is already there in the country. So it is already there. Only thing is, point of care ultrasound, it is an evolving process. Right now, if you see 10 years back, there was no point of care ultrasonography program in the country. Now, with the continuous effort by All India Institute of Medical Sciences, Academic College of Emergency Experts, Indus EM group, and it has evolved over a period of time, 10, 15 years, that every academic residency program are well trained with point of care ultrasonography. Number one, there is a lot of research output coming out in point of care ultrasonography. So it is catching up. So that is number one. So it is catching up. We're still young in this thing. Every new thing has got its time. But yes, we have put even in the proposal of even in our policy, national policy, we have used point of care technologies, which includes point of care ultrasound as one of the core competencies for even providing even in the all medical specialty, clinical specialty. So that is already done. So that means it will evolve. So once you have more science and education into it, even the PNDT Act will not be a trouble. So that is one. And second is an adoption and awareness bias. Definitely, it agrees. I do agree with that. So it is a slow process, but definitely it is life saving. So one of the questions by Nachiketa Mohanty ji uh, is all institutions using USG fall under its purview. That I do agree. Even we are also following into PNDT Act. Here we have registered ourselves, and there is no issue. And regularly they come for a visit, and we show them everything, and there is no problem. If you are doing say gynae ultrasonography, we don't do gynae ultrasound. The gynecologists they do, and the radiologists. There is a specific form available. So we are not using in point of care, even training of this academic residents across the last 10, 15 years. We have not trained any of the gynecological ultrasound to this academic resident, because that is not my forte or our forte. When they rotate to the gynae, this thing they learn from the gynecologist, but they don't practice. So that's what it is. And so we are very clear about that. So that's why the problem, the act is there and it should be there. But yes, it does not prevent from doing it.
Thank you for that really thorough, excellent answer.
Yeah.
We have a question in the chat from Dr. Grunauer, one of our intensivists. She's asking if you think in times of COVID, of course, can we achieve ultrasound competence and training virtually? And have you had any experience with programs that you found are useful? Is there a program that you could potentially recommend for teaching ultrasound virtually?
Very good question, and thank you for that question. So we as a group, we have our course. We have designed, the course from All India Institute of Medical Sciences at Delhi, and actually we from our WHO collaborating center. So since our is a WHO collaborating center for the Southeast Asian region, we have devised that, and we had training sessions up to 1,000 people. We have trained online. So there is we have a almost 2.5 hour module for this COVID focus, and we have done it online. So yes, it can be achieved, because you don't have to teach everything. One should focus on lung ultrasonography, and we have focused on that. Those who are trained, so there are different level of trainers. Yes, those who are already have got say some knowledge about point of care ultrasonography, they are already baseline knowledge. So we have our target is to those people who have got baseline some experience about point of care ultrasonography. We teach them the module, and it is well received. How much they are doing on the ground is difficult to say, but the module exists. And we also tell that what is the where to use. Like you're using in the triage, what is your objective? If you're using in the ER, what is your objective? If you're using it in the critical care setting, what are your objectives? And we will tell the algorithms and the finding. So it is there, and if somebody is interested, you can mail us, and I think that can be done. online teaching. That is what we also look forward as a WHO collaborating center, even with Japigo, and very much interested, to disseminate through online. How much we can do, we can have a discussion separately.
Thank you so much, Sanjeev. I think just to chime in here for the in-country teams, I understand that ultrasound is very exciting. For those country teams that have had increased budget or supplemental funds, we can most definitely discuss building this into both the technical assistance delivered and possibly consumables. One of the challenges is, though, that procurement of items is generally beyond our scope of work. And so we would perhaps need to consider which facilities already have ultrasound available and what types of ultrasound they have available. So just one thing for you to think about is, if you do want us to discuss ultrasound in addition to your work plans, we can definitely do that, but consider which facilities you would like to focus this effort on, have a justification of why those facilities, and also if they have an ultrasound machine already available. I'm concerned that we will not get approval to buy ultrasound machines with the secondary tranche of funding. Dr. Bhoi, thank you so much for the presentation today. I think we appreciate your willingness to collaborate with us and teach. As we design the technical assistance for the next 3 to 6 months, we'll be sure to reach out to you. I also just want to thank you on behalf of our India team. I know you've been quite instrumental in delivering the webinars and the training to our India-focused colleagues as well. So thank you on behalf of the whole of Japigo for everything you're doing and for this collaboration.
Thank you, Bhakti, thank you, and thank you all. Thank you.
Thank you, everybody. And we'll close here so you have a minute or two before your next call.